Where is your question?
Okay. Hello.
32 seconds. Wait, you'll hear the bell.
Okay.
Right now. So if you have read and understood, considering it pathology station, surgical pathology station, please begin. Yes. So can you please tell me what is the most commonly, what is your provisional or differential diagnosis for this patient?
Ma'am, I'm not seeing anything.
Why not? Can others see?
Yes, madam.
Yes, we can see, ma'am.
Yes, we can.
Oh, what key se?
Can you see now?
No, ma'am.
Should I pause the
Okay, you just tell me now. I write it down in chat.
candidate instructions? In this station, your knowledge and professionalism of surgical pathology in clinical setting will be tested. Question is, you are dealing with 155 years old female who has presented on post of day 4 with surgical site infection, post cholecystectomy. He had gall bladder cancer and pseudomembranous colitis. Okay, so if you can tell me what are the most common cause of carcinoma in UK, gallbladder carcinoma in UK?
Chronic cholecystitis and cholelithiasis.
Okay, very good. Most common histological feature, what are the most common histological features which are seen?
Adenocarcinoma.
All right, good. Can you tell me this gallbladder carcinoma most commonly spreads where? To which organs?
Liver.
And
Porta hepatis, CVD, common bile duct, stomach, duodenum.
very good. Okay. Can you please tell me what are the most common risk factors which lead to the formation of gallbladder carcinoma?
Female, obesity, cholelithiasis, gallbladder polyp more than 1 centimeter, age more than 70 years, family history, smoking.
Yes. All right. This patient has presented in front of you with the surgical site infection post-operatively. What might be the cause or the reason?
Okay, there may be local sepsis, bacterial infection probably.
Okay. What would be your first take of action? What would you do?
My action.
Yes. What would you do? The patient has
Okay.
come to you and wants help.
Okay.
So what would be your first action? What would you do?
Okay, first of all, there will be, I have to do a surgical exploration in the setting of high suspicion. Then I have to take swab for CS. Then I will allow drainage and clean the wound. And I will start broad spectrum antibiotic according to trust protocol and consult with microbiologist. Then after getting the CS report, I will proceed accordingly.
Can you tell me what is the gold standard which is taken or which is done when a patient has when a patient presents with surgical site infection post-operatively?
It's a small keyhole incision should be done. It is actually extensive surgical debridement.
Or surgical exploration.
Surgical.
Okay, what are the most common organisms which are present in surgical site infection?
Staphylococcus aureus.
Okay, right. There is another term which is called necrotizing fascitis. Can you define the term or have you heard of it?
Yes, necrotizing fasciitis is actually polymicrobial synergistic infection, and it has a number of microorganisms works in here. So it needs extensive surgical exploration and um, surgical debridement until viable tissue arrives.
Okay,
And
what are the common organisms which are seen in case of necrotizing fasciitis?
Streptococcus pyogen, Staphylococcus aureus, Clostridium perfringens, Bacteroid fragilis, E. coli, and Pseudomonas.
Okay, what is the criteria to confirm your diagnosis with necrotizing fasciitis?
First of all, I will see the clinical pictures of the patient. Signs, symptoms like crepita cellulitis will be present. Then I will go for the lab result. It calls laboratory risk factor indicating necrotizing fasciitis. It includes WBC, creatinine, CRP. So
Yes.
the serum sodium.
How much should be the CRP and how much should be the value of WBC? Can you please tell?
Okay, the CRP should be more than equal 15 milligram per DL, and the WBC, there are some points for WBC like less than 15, then more than
Yes, yes, all right.
less than
Okay.
15, 15 to 25, and more than 25.
All right. Who would you involve in the management of this particular patient?
Okay, I will involve a MDT to approach this. I will include microbiologist, plastic surgeon, I2 specialist.
And pathologist?
Pathologist. Yes.
Would you or would you not involve plastic surgeon in it?
Yes, plastic surgeon.
Okay, good. This patient also presented with pseudomembranous colitis. How would you manage that?
If the patient has it will according to the sign and symptoms. If it is mild, then we will go to the pseudomembranous colitis. Okay.
Yes.
It depends on severity. If it is severe, then I will proceed with surgical critical care of surgically ill patient. Then I will stop the antibiotic. I will start fluid resuscitation of the patient. Then I will give the first line treatment is oral vancomycin. Then the second line treatment is fidoxamicin. Then if it doesn't work, then vancomycin with higher dose with or without IV metronidazole.
Post-operatively, patients normally present with blood in diarrhea. Can you mention 4 different differential diagnoses?
Yes, the first one is pseudomembranous colitis, ischemic colitis, surgical acquired diarrhea, and inflammatory bowel disease.
Okay, right. If colonoscopy is done, what kind of colonoscopic picture do you expect to see?
Okay, there will be yellow color pseudomembranes, which it will have eruptions.
Exudate of what color?
Exudates of white color with inflammatory debris. WBC also.
Okay. Can you tell me the pathogenesis of pseudomembranous colitis?
Yes, ma'am. So there will be a prolonged history of giving antibiotic. Then the normal colonic bacteria is destroyed by this antibiotic, and the Clostridium difficile enters. Then it causes release of the toxins and disrupt the epithelial function. Then volcano-like eruption occur at the neutrophil from the colonic crypts, and mucopurulent pseudomembranous occurs and bloody diarrhea happens.
Okay, what if you have explored and the wound was dry and there was only erythematous around the site of the incision? What would you do next?
Only erythematous.
Yes, and tenderness, nothing else.
Erythematous and tenderness. I will start
you
the
think
antibiotic.
of necrotizing fasciitis.
Okay, necrotizing fasciitis.
Then
I will.
Yes. Emergency.
Then I will
surgery.
emergency ABCD protocol, IV fluid, antibiotic, and
No,
send the
then
blood
you'll
for
do the
CS.
emergency surgical
Oh, sorry. Surgical exploration. Yes.
Yes. This you should know. Okay, what is MRSA?
It's a methicillin resistant Staphylococcus aureus.
When would you expect that? In
Methicillin.
post-operative surgical site infection. How would a
Mm.
patient with MRSA present? How frequent are the cases with MRSA in post-surgical site infection cases?
Can I come back to this question later?
Yes, well as one. I was just making sure you know everything on the topic.
Okay, ma'am.
Right. How would you monitor the patient suffering or going through surgical site infection? What are the most important clinical management that you'll keep in your mind?
The sign symptom.
No, patient management. What would be your aim? Yes.
So I will see the vital signs of the patient.
Okay,
If it's
very good.
stable or not. Then I will
All
go
right.
for the blood investigation, that the WBC count is good or not, the platelet count, and
Vitals
will
and
just-
then urine output.
yeah.
Diarrhea, you'll make sure it settles. If there is any fever,
Fluid
you'll take care
resuscitation.
of that. Yes.
Yes.
Very good. Okay. Good. Thanks. Yes. Thank you.